real-world data become more and more valuable, and that we can use this to create real-world evidence. So this is why my colleague Bart Meuris and myself have decided to come up with this Avalus Clinical Confidence, or ACE, registry, with the aim of having an all-comers registry. This means we have no exclusion criteria except for patients below the age of 18 and salvage surgery. Meanwhile, we are negotiating with 46 centers across 15 countries in Europe, and at this moment we have active enrollment of 20 centers within 9 countries of Europe, and I'm really happy to announce that from yesterday on we have 350 patients included. So I give you a first glimpse of our results. We have a mean age of 72 with a BSA of 1.92. A mean Euro score of 3.4, and what makes our database or our registry quite unique is the huge amount of combined surgeries. Of these 319 patients, so the analysis was done about 10 days ago, we have 100 patients that the AVR was combined with CABG. In 20 patients it was combined with a mitral surgery, in 7 patients with tricuspid surgery, in 30 patients with ascending aortic surgery, 12 had an ablation, and in 22 patients other concomitant surgery was performed. About 58% of the single AVRs was done in a minimal invasive way. 4% were redo cases and 9% were urgent cases. Now, first glimpse at the results. We have an early death rate of 2.5%, which is just 1.4 in the single AVR group, but I just remind you to our Euro score of 3.4, so it's still quite good result. Stroke in 1.6% of the cases, pacemaker implantations in 2.5%, paravalvular leakage 0.3%, and then I think, in my opinion, quite favorable hemodynamics. Peak gradients 21.9, mean gradients 12.2 millimeters of mercury, an effective orifice area of 2 square centimeters, and an indexed value of 1.03. These numbers do not significantly differ with the single AVR group. Now here you can see in these figures that there's a clear trend to have lower mean gradients with increasing prosthetic size, which is of course expected, and you can state the opposite for the effective orifice area. Now if we have a look at our indexed effective orifice area and we take this cutoff that is quite often used in the literature of 0.85, we see that in 67% of our patients there is no patient prosthesis mismatch, which is in comparison to other numbers published in the literature also about other valves, a really nice and good number. Considering our 1-year follow-up, these are only 73 patients at this moment. 83% of them are functioning in New York Heart Association Class 1, and also our echocardiographic data are quite nice, but as I've said before, only 73 patients. Then I made a small comparison with the Paragon trial, so you can see that our early death rate seems to be much higher, 2.5% versus just 1%, but again I refer to the Euro score of 3.4%, and of course the only explanation for this is the design of our registry. We have on purpose created an all-comers registry to have, to provide you with real-world data, while in the Paragon trial there were several exclusion criteria. Another difference is that we see that there is more minimal invasive surgery done for the single AVRs with or without the ascending aorta included. And then if we have a look at the hemodynamics, at the first glance we have the impression that we have slightly better data, peak gradients of 21.9 versus 24.2, with a mean gradient of 12.2 versus 13.6, an effective orifice area of 2 versus 1.57, and an indexed value of 1.03 versus 0.80. I have to admit we have only 319 patients, so we are just at 1/3 of our total projected inclusion patients. However, we have already been thinking a little bit to explain these differences. First of all, we have to make the remark that that we are using center-reported data, while in the Paragon trial, the echocardiographic data were analyzed by an independent core lab. And the second thing is we think there might also be an aspect of the learning curve for sizing. We have to admit that in the Paragon trial, it was about 7 years ago, this Avalus valve was quite new on the market, so the learning curve for a lot of surgeons might have been in the beginning. While at this moment it might be that we have in our registry some very experienced surgeons regarding to the implantation of this valve. So these all might play a role in the differences. So in conclusion, the ACE registry is providing us real-world data based on an all-comers principle, and hopefully in the end will provide us with some real-world evidence. At this moment, I think we look at least comparable and maybe slightly better hemodynamic data compared to the Paragon trial. We are, I think, offering a solid proof of the Avalus clinical performance. And for the guys here in the room that are actively enrolling or are thinking to participate in this study, our final aim is to include 1,000 patients. So I hope with giving these preliminary good results that I can encourage you to keep implanting or to start implanting. Thank you.